Okay, we are live. I'm here today with Dr. Enrique Aranda, who is a gynecologist with a special focus on functional medicine, and he does minimally invasive gynecological surgery. He is passionate about helping women navigate different hormonal transitions, such as perimenopause and menopause, through evidence-based root cause approaches, functional medicine approaches like diet and lifestyle, hormonal support with bioidentical hormone therapy when possible. He's dedicated to empowering women with clear, practical, and scientifically grounded information to optimize their health. So welcome, Dr. Enrique. We're very happy to have you here with us today. And
Hi.
we are going to start with speaking about why are we talking about perimenopause and menopause? What is the importance of this?
First off, I think it's a topic that is still talked about so little. And I believe that for decades, menopause has viewed as something women simply had to endure rather than understand, let alone treat. And I would say that unlike pregnancy, which is a topic that everybody talks about, and whenever someone's pregnant, they made a party out of it, menopause and perimenopause, they're rarely discussed openly. Even though it's important, every woman who lives long enough will experience it. Yes. And I think part of the problem is that many healthcare professionals, us, we received very limited formal training in menopause management. At least in Mexico and in the United States, I know menopause is not part of the curriculum during residency. I mean, you might have a course or some certain hours during one of your years, and that's it. And as a result, symptoms, when women come to visit us, symptoms are often normalized, the women is dismissed, or their symptoms are just attributed to stress, to aging, to simply being busy or whatever. They're basically gaslighted because of this. But the good news is that this is beginning to change. At least that's my perspective. And more women are reading more. They're becoming more aware. They're starting to ask questions to get or be better informed and demanding better care.
Yes. And so when do women first typically start menopause? When is the normal menopause or perimenopausal window start?
Okay, so menopause is defined as 12 months without menses, 365 days. So menopause is a specific point in time. It's that 366th day. So after my year without menses, the day after that day, I'm in menopause by definition. And starting that day on, women enter post-menopause. Yes. And it's I want to say it's like a third of their life is going to be in that new postmenopausal stage. And perimenopause are the years when the women transitions to that stage, which is, 2, 8, 10, 12 years. Some resources say that before the starting of menopause.
Okay. So a woman, if I remember correctly, the average age of menopause is around 52 years of age?
Yeah, in America, it's around 51 years of age.
Okay. So a woman typically would start her perimenopausal time essentially any time after 41. Is that correct?
Early 40s. I mean, if you read about it, they're going to say early 40s, but really the hormonal shifts start way earlier than that. So around 35, women can start having hormonal fluctuations, not necessarily affecting her period, so she might not be even aware of it. But hormonal changes are starting that early, and that might cause symptoms. I would say inspecific symptoms, but the hormonal shifts can start as early as 35.
And what are the most common symptoms? Because you mentioned symptoms. What are the most common symptoms women are coming to you with, or the ones that typically bother women the most to, really seek counseling or care or support around it?
I want to say, Emily, remember this is a systemic condition. So yeah, it's caused by fluctuations in sexual hormones, estrogen, progesterone, testosterone, but the impacts are systemic, because as we know, we got hormonal receptors in every single organ of the body.
Yes.
So symptoms can be as inspecific as sleep disturbances, which is a huge one. I want to say 1 out of 5 women that I see complain about sleep disturbances or insomnia. Another symptom, very common symptom, is weight gain. We know that as hormones start shifting, especially estrogen, weight is distributed in different ways that it used to be. So women start gaining weight, especially around the abdomen. So that's another huge complaint. Another one I would say is mood changes. They just don't feel themselves. They sometimes are sad, sometimes they're just moody, sometimes they're just anxious, and they don't know why. And this changes from day to day. So that's another thing about perimenopause. Perimenopause, hormones are still present. Periods can still be regular, but hormonal changes are happening. Someday, hormones are sky high, especially estrogen, and so some days they just crash, and that is felt by the woman. I would say another common symptom is low libido. That's a huge one. Brain fog, lack of energy, fatigue, and those symptoms are hard to attribute to hormones just because they might overlap with, for example, thyroid conditions.
Yes.
And I've noticed, and I want to hear your point of view about it. I've seen many women during perimenopause, when I order lab tests, their thyroid panel is kind of like abnormal, I want to say.
Yes.
Either TSH is frankly high, or they can have a normal TSH, but their thyroid hormones T3, T4 are low.
Yes.
So I know as every other system, the thyroid system gets or suffers during perimenopause, but I've noticed women suffer a lot because perimenopausal symptoms are directly related to lack of energy, fatigue, dry skin, hair loss. But I also know these symptoms are or can be attributed to thyroid. So it's like a double whammy during this stage.
Yes.
I don't know, what are your thoughts about it?
I think the chance of having hypothyroidism or thyroid disease increases as we age. So just naturally, you're going to have that potential greater as you get into the perimenopause and menopausal time. But then also, I think such a big impact on the thyroid gland is stress, and the hormonal changes in menopause is a huge stressor for a lot of women, especially if they're not sleeping, their metabolisms change. So when I order blood work for thyroid, I'm also, speaking of weight gain, I'm also looking at insulin levels, because this can also change during menopausal time. So I really think the more I practice medicine, the more I see the connections between every system in our body. We're not just one, menopause is not just happening to the ovaries. There's many different factors going on in the body. And I think the best approach is looking at the multifactorial piece and supporting where we can.
Yeah, for sure. And do you treat, when you see a woman, 44, 45-year-old woman,
Yes.
She's going through perimenopause, how do you approach those thyroid symptoms, and even thyroid symptoms that are somehow proved on a thyroid panel? Do you approach her as a hypothyroid patient, or do you treat her hormonal imbalances that you assume are taking place because she's in perimenopause, and that somehow can fix her thyroid? Or how do you approach it?
That's a great question. So when I look at thyroid health, first I'm looking at TSH, T3, T4, and both thyroid antibodies. I want to know the ratio first between the T4 and T3. So there's some women where their thyroid is actually putting out enough T4 hormone, but they're having trouble converting it to T3. And this is especially important as a woman's going through menopause, perimenopause, because that conversion is heavily influenced by stress. So we're looking at that. We're looking at the thyroid antibodies to see if there's an autoimmune attack on the thyroid gland. And then if I'm really defining true hypothyroidism as a very elevated TSH, usually with quite a lower T4. So does she have true hypothyroidism where her T4 is not within range and her TSH is really high? Or does she have subclinical hypothyroidism or Hashimoto's hypothyroidism or a conversion problem? So it's really narrowing down what issue with the thyroid is going on. And then, like you say, I'm looking at the estrogen, progesterone. I think progesterone particularly has a fairly big impact on thyroid health and thyroid function. So is the progesterone really, really low? And do we need to support that to help rebalance a subclinical hypothyroid picture? But if the woman's truly hypothyroid, then I'm treating her as hypothyroid, but really it's, again, asking the question, why is she hypothyroid? Does she have high thyroid antibodies? Is she not converting properly? And how did she end up with having hypothyroidism in the first place? Where do we go, again, going back to the root cause?
Yeah. I'm so passionate about the thyroid, even though the more patients I see, the more I become aware that there's a lot more that I need to know. And I'm surprised. I mean, if you log into Instagram, you'll see all these experts in hormones, especially the thyroid nutritionist especially, that I'm like, I'm sure there's a lot you need to know, but regardless. But yeah, I'm surprised the amount of patients that come in with, I would say, subclinical hypothyroid. I believe most of them are not clear Hashimoto's or a clear hypothyroidism with these high TSH levels.
Yes.
But I would say that the majority of women that I see, even though they don't know, they have an abnormal thyroid panel.
Yes.
And yeah, like you were saying, progesterone, well, in perimenopause, yeah, all hormones, progesterone, testosterone, and estrogen are going down. That's definitely. The three of them, the trend is to go down. But out of the three, the one that suffers the most and that stays the lowest throughout, it's progesterone. So
Yes.
it's not surprising that if you treat them with just progesterone, you might see improvements in her thyroid levels.
Yes.
I mean,
And I think that's, it's so important that you bring that up, that you're testing thyroid, because so many women are told with the thyroid gland that we'll just watch and wait, or we'll just wait till symptoms get bad enough or your TSH gets high enough that you need to be put on thyroid medication. But I really think there's so much we can do, again, when we're looking at the root cause or why the individual is having an abnormal thyroid panel, that we can support them, especially if we get in early enough, so that maybe they don't need thyroid medication, or if they do, it's only for a short period of time or a lower dose, instead of putting on thyroid medication for the rest of your life and say, that's it. If anything, you're just going to go up and up and up on thyroid medication, right?
Especially when it doesn't make sense. If you're treating someone with high antibodies and you just put them in levothyroxine, at the end, you're not doing nothing for the inflammation going on, which is
Yes,
the main cause why her thyroid panel is abnormal.
exactly.
But that's just how traditional medicine works. So I call it like a Band-Aid medicine. That's what we do. We see something abnormal, you just want to treat that and make that appear normal, but you're not healing.
Exactly. So, Enrique, when a woman comes to you, there's a debate in medicine amongst naturopathic doctors and functional doctors that I know in terms of testing hormones. Do you test the estrogen, progesterone, DHEA levels in women that come to you?
I usually test them, but one important thing in this stage is that testing during perimenopause can be challenging because hormone levels, as I said before, fluctuate dramatically. They're not absent. They
Yes.
fluctuate day to day. So you can test her today and do a snapshot of this moment, and hormones are going to appear completely normal, even though the woman is feeling miserable. And then you can test her the next month, this same day, and the lab results are going to appear like a menopausal women with the estrogen low, the FSH sky high, and the women feeling terrible. So it's a little bit challenging. Sex hormones, I don't usually test them on a routine level unless it's indicated by the patient. What I do include on my general lab test, I include a thyroid panel.
Yes.
I include iron studies and ferritin, especially if that lady has been bleeding and she's complaining symptoms that could be compatible with anemia. I test her for vitamin D. I test every woman for glucose and insulin together, always. I want to see her lipid profile. I want to see her liver. How is her liver, especially if I'm thinking that I might put her on hormones. And again, I just, the reproductive hormones on selected patients when clinically, I believe they're useful.
Okay. Yeah. So, and then once you see, so tell me a little bit more too about when you would decide to put a woman on hormones versus when you would decide to do more, just diet and lifestyle, maybe herbs and supplements. Do you have a defining, aside from a patient preference, if a patient's coming to you and wants these hormones, well, I understand, patient wish, but from a physician standpoint, what's your defining factor of how to navigate that?
So the most important things to consider hormones, it's symptoms, right? I mean, we're not treating lab tests, we're treating symptoms. So if she feels whatever symptom she has, that's when you can consider hormones. But this is the important part, because you just not prescribe hormones expecting them to do whatever magic the woman wants them to do.
Yes.
It has to do a lot. The success of hormone therapy has to do a lot with how she is metabolically. So if that woman comes in and she is insulin resistant, because I see an insulin of 20 in her lab test, or let's say her lipid profile is sky high altered, or these women comes in and she's been telling me that she hasn't slept in months and she's been gaining a lot of weight, and I see her thyroid panel and her thyroid panel is clearly out of balance. I know that women metabolically is not in the best of the shapes to receive hormonal therapy. So I always use this analogy. I tell them, hey, so your body, it's like a field, right? I want to plant this seed, this mango seed. I want a mango tree and I want a lot of fruit. If I plant this seed on a dry soil where barely rains, there's no sunlight that hits the field, I will put the seed and I won't get mangoes. I assure you, I won't get mangoes. I can get a little stem and that's it, but I definitely won't get mangoes. On the other hand, if my soil is fertile, if it has the nutrients I know the mango needs, if the sunlight hits the field whenever it needs to be hit, if it rains on a regular basis, then I have great chances of getting a tree that gives me mangoes. Same thing with your body. If I just throw in the seed, which is hormones, or the hormonal therapy, on a field that is not ready to receive them, I'm not going to get the results I'm expecting, and you won't feel any better. And I will just miss a great opportunity of helping you because I'm not treating the field before I give the hormones. So what we need to do in that lady, okay, you're feeling all these symptoms that you're telling me, but we need to correct your metabolism first. So there, it's obviously nutrition, helping you in every way we can to make you sleep, stress reduction, exercise, and some specific exercises for this life stage. But every single lifestyle factor that we know and that we consider the pillars of health during this stage, they become more relevant. So you need to improve the field, and if that's not enough, which sometimes improves a little bit, but it's not like they are like they were before all these hormonal shifts. But once she becomes better and you can see that improvement in lab tests, then you can start hormonal therapy, hoping and almost being sure that this lady is finally gonna feel a difference. I don't know if that makes sense.
Yeah,
but metabolism is very, very important. The metabolic field, it's very important in order for hormones to work.
And so in that same line, how do you feel about GLP-1s improving the terrain that way? Do you use them, access them, or how do you feel?
I personally, I'm not using them yet, but I'm starting to see more and more patients that are on them.
Yes, huge.
That when I start them on hormone therapy, they seem to be doing better.
Okay.
So I'm very optimistic. I'm very hopeful that peptide therapy is going to really improve our hormonal therapy when indicated.
Yes.
Are you using them?
I don't use them personally, but I have a lot of patients that are put on them by another provider. And like anything, some of them get great results and some of them don't as much.
Yeah.
I think it's individualized, and I think we still have a lot to learn in the peptide arena as well.
Yeah, me too. Especially because in perimenopause, weight gain it's very prevalent, very
And
prevalent.
why does weight gain happen so much? Why is it
First
happening?
off, because of estrogen going down, there's a specific pattern of fat distribution during this age. So normally, before perimenopause, when woman is in the peak of her fertile stages, fat tends to go to the buttocks, the thighs, but not to the
Yes.
belly.
Right.
During perimenopause, due to the hormonal shifts, especially estrogen, as I say, fat tends to redistribute to the abdominal area, to the viscera, to the visceral fat. That's one. The other one is during this stage, women have trouble sleeping. So they're
Yes.
constantly on a stress level. Their cortisol is constantly high. They're on this chronic stress response, and that keeps the body like on an alert all the time. The body needs to have resources to keep the fight, and one way to keep resources is I won't let them go. So even if you do a diet, even if you lower your caloric intake, I might lose weight for a little bit, but eventually the body, I'm going to hold on these resources because I need to keep this fight that seems to never stop. The other thing is, since they're not sleeping, they're not having the energy to go and work out, so that also impacts on the weight. Since they're not sleeping and they are crashing during the day, they are needing constantly to snack on something. And usually it's a high caloric snack. And that doesn't help either with weight.
Yes.
It's as you can see, there's a lot of factors that impact on weight. It's not just that hormones are crazy and now I'm gaining weight. Yeah, it has to do a lot. But there's a lot we can do to try to manage your weight aside from the hormonal therapy, which many women believe that just by putting them on hormones, magically they're going to start losing weight. No, hormones do magic, but the field, again, the metabolic field needs to be on the best of the shapes in order for them to work.
Yes. Yeah, makes sense. And again, it's multifactorial. It's often never one reason, but it's looking at the many systems in the body and how they're changing. So is there, and you may or may not be able to answer this, but aside from how I work in my practice it's a similar approach to you. I'm looking at diet and lifestyle first, and maybe using herbs and supplements before the use of hormonal therapy. Are there certain herbs or supplements that you find have great evidence for that you typically will think about for different women when looking at menopausal symptoms, or is it really a case-by-case basis?
The truth is, I've read about them. When I did my natural nutrition studies, I certainly was thought about them, but I really don't use specific herbs instead of hormones in my practice.
Yes.
What about you? I've heard about black cohosh, for example, but
Yes.
I really have no experience. I would love to, because many women, either because they don't want to use hormones or hormones can be indicated on them, obviously herbal would be a great option.
Yes. So herbal, when we do have some really good literature around it, but like anything, first with herbs, I always say is you've got to have a good source of herbs. There's a lot of different herbal supplements now on Amazon and different websites that might not be anywhere close to the potency or the dose that is needed to replicate some of these studies. So first you need to know, okay, what's the dose? Ideally, you're working with a provider or specialist that understands this information. And then you're making sure that you're getting a quality supplement within that dosage that's going to replicate the potential improvement from the literature. But some of the things I look at first is actually chaste tree or vitex. I really like that herb because it supports the progesterone pathway so much. There may also be benefit for fertility because this is something we haven't touched on yet. But there's a lot of women, at least in my practice, that are in their late 30s or early 40s and still hoping to have another baby. And
Yeah.
so Vitex and supporting the progesterone, maybe sometimes estrogen, of course, is really needed too. But usually, as you mentioned, progesterone is the first hormone that might drop and be. Then for just managing symptoms of menopause, I look to black cohosh and the Cimicifuga, the Ractea racemosa, the wild yam complex. So again, it's kind of supporting that estrogen and progesterone pathways, but in a much lesser, more natural way. They're not going to bind strongly to the receptors. They're more of a phytoestrogen process where they're binding loosely. So maybe we're not going to have the same magic that the hormones will have. But again, sometimes that's really patient preference. They want something more mild to get them through the change of life instead of something so strong.
And for example, when you were talking about specific that herbal, it's not just any commercial herbal that you go to the pharmacy or you order online.
Yes.
But can you get them? Like can anybody, if I prescribe them, like specifics, can they get them or they need a special provider? I'm asking this because most of my patients are Hispanics, and I don't think they're gonna have access to a herbal pharmacist. They won't.
Yeah, so first they have to make sure, ideally you're looking for supplement companies that are third-party tested. I have my concerns about Amazon because Amazon has been known to sell some fake supplements or some replica supplements. So you want to look for a brand that's been third-party tested. And let's say there's, for example, Designs for Health or Pure Encapsulation. Some of these brands are available at Amazon. You want to make sure that you're getting those brands from the Designs for Health store on Amazon, for example. So if it's a third-party seller, there could be some variations in that. So it's got to be third-party tested, GMP certified, and certain brands will say, okay, practitioner recommended. So they're using the evidence in the literature to help manufacture the correct dose with the correct potency. So there's definitely a way for sure, but it's just making sure you're double checking that you're getting a good product.
I love it, and I think I think it's very important to have those resources on the tool set, just because again, many women, they're not, for whatever reason, they're not ready to start on hormones, or they cannot take hormones, and the more options we have to offer them, the better.
Yes. And so again, you might be using this or not, but I should ask you, because this is a big thing too, the creatine. So many women, menopausal, perimenopausal women, have started creatine. Do you use this in your practice, or what are your thoughts?
I recently started using it. This came from an article that I read that recommends creatine. So now I'm starting to include it in the supplements or in the complementary tools that I give them. I include creatine, if and only if they're exercising, which is they go hand by hand. Exercising, especially strength exercise, weight exercise, is a must or should be a must during perimenopause. And if they can complement that with the creatine, that's a good.
And so what will happen if they're not exercising and using creatine?
I don't know if the effects are going to be the same. I don't know. I mean, I usually prescribe them in combination. I've never said, forget about exercising or don't put too much effort on that. As long as you take creatine, you're good. No.
Yeah.
And again,
And you're using
from my experience, I cannot tell you much just because I recently started using it. So I don't have yet the results to compare between this one that use it and this one that don't. Oh, it's a huge difference in this or that.
Yes.
Have you been using it, or do you personally use it?
I don't use it too much, but I know some women really find it beneficial also for, again, like you say, building lean muscle with exercise, right?
And building lean muscle is very important because, again, due to the lack of estrogen, women start losing muscle.
Yes.
And muscle is one of the biggest, if not the biggest, system involved in metabolism in our bodies. So we need that muscle that we are losing. So that's why strength muscle becomes more important at this stage.
And also for bone density. Right?
And also for, definitely.
So is there anything that you find is a really big myth or misconception about menopause or perimenopause? And I'll kind of add in this around the fertility piece. Do you think a woman can still have easy pregnancies in their perimenopausal years?
I would say it depends a lot on her age. And I think this is another topic for another live, but infertility, it's a big thing nowadays. I don't know if I know it was not like this years ago, or at least when we were younger, we didn't hear it as much as we hear it today.
Yes.
So I'm sure there's something we're not doing right nowadays that is impacting directly to the fertility. But if that lady becomes pregnant during perimenopause, again, it all goes back to what age are we talking about? It's not the same. It's not the same a woman getting pregnant at 46 that a woman getting pregnant at 38, and they're both in perimenopause.
Yes.
So age for me keeps being the number one factor in prognosis for carrying a pregnancy to term or not.
Another question I have for you is with hysterectomies. So in Canada, at least for a long time, I'm seeing less recommendations for it than I used to. But when a woman reached perimenopausal time, especially if there was fibroids there, hysterectomy was recommended. What are your thoughts about that? When would you recommend a hysterectomy versus not? Any thoughts about this? Because do you perform hysterectomy?
So I'm sorry, I lost you a little bit. You were saying Canada, and then I lost. I mean,
okay.
There was
in Canada. Mm-hmm. I'm seeing less now, but I'm seeing a lot previously and still now, a woman reaching her perimenopausal or menopausal years, she's having very heavy bleeding, and she's recommended a hysterectomy. But I think that maybe there's other things that we could do before the hysterectomy. Yeah. I'm wondering what your thoughts are this, because you do perform hysterectomies. Yes?
Yes. So I want to say this. This is a topic that I like. So remember, in traditional medicine, we're trained to fix problems. We're trained to prescribe something in order to stop seeing whatever symptom you're having. A woman comes here because she has irregular bleedings. Well, we're trained to prescribe a birth control pill, and that way you're going to see a predictable month-to-month bleeding. We're not fixing the problem that caused the issue in the first place, but at least we're putting a Band-Aid to the issue, which is abnormal bleeding. So I think offering hysterectomies is kind of like the same thing. It's probably a bigger Band-Aid. It's a more complex Band-Aid. We've gone through the different options we had before, offering a hysterectomy, but at the end, it's a Band-Aid fix, sometimes. Because there are many things we can do in order to try to fix the abnormal bleeding that lady is having. And the most important thing to know is how hormones behave during perimenopause. And I think that's a huge gap we are still having in medicine. If we know that estrogen is peaking some days and dropping some others, and that it's progesterone the one that is staying low, and we know these behave, there's a lot to do to understand then what's going on. Because if a woman comes with, I don't know, with heavy bleedings, well, you might think, well, yeah, because you're estrogen dominant at this point, you have a lot of estrogen compared to progesterone. Maybe what you need is just to balance each other. And there are many ways to balance. We can use bioidenticals, we can use intrauterine devices. We need to make sure there's not something organic inside the uterus that's making you bleed. And if there's something, then there's ways we can go in and get that thing out, that polyp or that fiber or whatever, in order to help with your bleedings. But as you were saying, there's a lot to do to try to fix the abnormal bleeding before going to hysterectomies. Yes, some women need it, but I do believe that we are over-treating them with the hysterectomies nowadays. Even though you're getting to see less, I still think we are over-operating on women that could have been fixed in a more conservative way.
Yes. Okay. Another question I have from someone that had emailed me with the question is dermatitis or eczema during perimenopause or menopause. Is that more common? And if so, why is it happening?
It is. I see it a lot. The thing about these inspecific symptoms of hormones, because again, if a woman at 45 started having these, these breakouts, most likely she won't think they're related to her hormones. Or if she starts having these, these joint pains, she won't relate them to hormonal changes. Even her doctor won't relate them to hormonal changes. But we gotta remember, as I said before, there are hormonal receptors in every single tissue of our body. Skin, definitely. So whenever hormones start shifting, skin is one of the organs that sense it. And either they break out with acne when they have never had acne, or they have these rashes, like the dermatitis, person that was emailing you. And once we discard that these whatever issues in my skin I'm having are due to a dermatology point of view, then we can think about hormones. And most of the times, whenever this lady has gone to a dermatologist and treated the rash the way the dermatologist told her, and it doesn't work, so now we can assume hormones have a lot to do with it, and you treat them with hormones, most of the times they do a lot better. So yeah, skin is one of the symptoms that show us those hormonal imbalances that are happening during this stage.
Yes. Okay. Another question here, Enrique, is the birth control pill. What are your thoughts about that? And again, this is a huge debate in medicine, the benefits versus the risks. Do you see it to be helpful in perimenopause, or do you see women that have been on birth control pills for years have a different menopausal time versus that woman that never took birth control pills?
Yes. So birth control pills, they're a useful tool. Again, like hysterectomies, I think we over-prescribe them. We want to fix everything with hormonal birth controls. And during perimenopause, it depends. I mean, if you're giving hormonal birth controls instead of hormonal therapy, no, we're not doing the correct thing, because they're not the same. Yes. But if this woman comes in because she's bleeding a lot, and you gotta do something in order to make that bleeding stop as soon as possible, well, maybe a birth control. In the meantime, while we find out why are you bleeding that much and start treating you properly, I can put you in birth control pills, because I don't want you to keep losing blood. But again, hormonal birth control pills are not the same as bioidentical hormones. They will never be compatible. And I have seen patients that took birth control pills in their younger years, and now they're more symptomatic than those that didn't. And I think that being exposed to your own hormones, the more you are exposed to your own hormones, that's like an investment on your health whenever those hormones start lacking. I don't know if so. The less you take birth control pills, the more exposed you are to your own hormones, the best is going to be for you whenever those hormones start going down.
Yes, that makes sense.
That I do see it. So and that's what I tell them. I mean, being exposed to your hormones is like investing. The more you invest on that, the more time you are exposed to your own hormones, the most likely your symptoms are going to be tolerable during those times when your hormones start coming down.
Yes.
That I do see. But again, I mean, I don't want to say birth control pills are bad, and I will never prescribe them. No, but I do believe that we overprescribe them, and they're not the magic pill that fixes every ill, for sure.
Yes. And the birth control pill issue is interesting because we know with Hashimoto's and thyroid disease, there are certain medications that may be a trigger. And one of the medications, again, a trigger is much more likely to be a trigger if someone's been taking it for 10 years versus a few months or a year. But oral birth control pills could be a trigger for Hashimoto's hypothyroidism. So again, it's interesting to start seeing all this information that's coming out about why things are happening and what we can do to prevent it. And again, it's not saying they're bad, but really maybe choosing some more time or an individualized program for people instead of mass, everybody gets a birth control pill just because that will stop the heavy bleeding and so forth.
And I think informing patients a lot more about the consequences, because everybody talks about, I don't know, the thrombo or thromboembolic disease caused by birth control pills, and that's really low, and you don't have risk factors, so fine. But I mean, that's obvious. That's the side effect that everybody knows, but it's not the only one.
Yes.
And I think we're not informing patients. We just putting them on birth control pills that easy without considering all these repercussions that it might have in her near future.
Yes, exactly.
And I'm not even getting into the deficiencies that you might have because of the birth control pill taking, which is another big thing.
Another thing.
And the stress on the liver and the stress on the gut.
Again, but I think there's a time and place for some of these, but I do believe they've been way overprescribed, or also maybe used for too long in individuals that maybe didn't need them. But I do think that women choose birth control pill because they think there's no other option when there is other option, but information is power, and we need to inform people about the other options, and then they can make an informed decision with the help of their healthcare provider about which option may be best for them.
Yes. And another thing about birth control pills that strikes me a lot is every doctor, it doesn't matter the specialty, because you see it in dermatologists, you see it in endocrinologists, you see it in OBGYNs, everybody prescribes birth control pills for whatever, for acne, for abnormal menses, for hair loss, for dry skin, for whatever. Yet, doctors are so afraid about prescribing hormonal therapy. I don't get it. I mean, birth controls are much more powerful than hormonal therapy. Yes. And I don't see them concerned about prescribing them as much as they do on the other one. So lady comes in feeling terrible. A good option would be put her on hormones, yet you don't because you are afraid of hormones and the risk of them causing cancer, but you just prescribe birth control pills to this 28-year-old girl that you just saw before this woman. So it doesn't make sense, but I think, again, it's information. Power is information, like you're saying.
Yes. Before we end, Enrique, is there anything else that you think is important to mention about perimenopause or menopause that we didn't touch on?
Yes. Look, I want women to understand this, and this has been my try to be my work, at least in my social media. They need to understand that perimenopause and menopause are natural, inevitable transitions, but suffering unnecessarily is most of the time at some point optional. This is important. And many women spend years believing that their symptoms are simply part of aging, and that they just should push through them because that's the way her mother did, or that's the way her mother taught her it should be, and that nothing can be done about it. But the reality is that education, lifestyle intervention, appropriate medical evaluation, and individualized, this is important, individualized treatment can make such an enormous difference on the life of that women. And again, my goal is not simply to help women survive this particular stage of life, but it's to help them understand what is happening.
Yes.
Education again. Because that way she can regain control of her health and thrive for the upcoming years, which is, again, they still have a half to a third of the life ahead of them. So they have to be thriving. They cannot just feel, they have to thrive. There's still a long way to go. They're probably raising teenage kids, which is it's a hard and difficult stage on its own. You gotta feel well.
Yes. Yes, and there is so much that can be done. And so, Dr. Enrique, where can people find you? What's the best way to contact you? Where they can, I'll put it in the information below.
The best way they can find me is through Instagram. That's where I try to stay more active. But even if I'm not that active, they can contact me through there directly from my Instagram. They can make appointments or ask questions or whatever through a link in my Instagram. So that's probably the best way.
Perfect. I'll put that information below.
Right now, my practice is basically online. So it doesn't matter where they are located. We can always have a conversation. And again, my goal is to give them information.
Yes.
Let them know what's going on today. Let them know that there's an explanation to whatever they are feeling. Because most of the times, if they don't know what's going on with themselves, forget about the husband or whoever's around her. So it's important for her to know and understand what's going on. And that way, everybody that surrounds that woman can become aware of what's going on and make things even easier for her. Because I understand it can be a hard stage. So the more we know about it, everybody that's around that woman, the better. Because again, this is a public health matter. Because 50% of the population are involved or will be involved at some point. But the other 50, us, we are somehow related to someone going through it, either a spouse, a partner, a mother, a sister, a coworker. So I think everybody should be informed and should know as much as possible as to what's going on during this life stage.
Yes. Someone just asked, what are we talking about? We're talking about menopause and perimenopause. Yes. Thank you so much, Dr. Enrique, for going live with me. And I will put the contact information of Enrique below, and maybe we'll have another chat again in the future.
Sure. Thank you, Dr. Lipinski. It was a pleasure talking to you.
Okay.